Welcome, everyone, to this webinar on shoulder instability in the female athlete. I'm Elizabeth Matzkin, and I'm an orthopedic surgeon at Mass General Brigham in Boston with a passion for taking care of female athletes. We have an incredible panel here tonight covering multiple topics from multiple perspectives, all of which are important in optimally managing shoulder instability in female athletes. I will introduce each speaker while they set up their slides before their talk, and we will have some time for questions at the end of the webinar. So please submit them in the question or chat. So first up is going to be Dr. Stephanie DeLuca, a primary care sports medicine physician who takes care of sports injuries with a particular focus in pediatric and adolescent athletes. She's going to talk about the epidemiology of shoulder instability in female athletes and look at some of the unique sex-specific risk factors, such as ligamentous laxity and hormonal influences. Dr. DeLuca?
And thank you everyone for the talk tonight. It's really an honor to be included in this great talk. So as Dr. Matzkin said, we're going to talk about shoulder instability in our female athletes. So the objectives of this portion of tonight's webinar are to gain a greater understanding of the incidence of shoulder instability amongst our female athletes, as well as to identify the sex-specific considerations that we should be taking into account in our female athletes regarding their risk for shoulder instability. So let's get right to it. So the incidence of traumatic unidirectional shoulder instability is higher in males than females. This is mostly due to a number of extrinsic risk factors, including more frequent participation in higher risk contact and collision sports. We think about those being, things such as American football or wrestling. In a cross-sectional epidemiologic study of glenohumeral dislocations that collected data from about 100 emergency departments throughout the United States between the years of 2012 to 2021, it was shown that females accounted for 30.5% of shoulder dislocations, while males accounted for the rest. So this is consistent with the literature that we know that traumatic unidirectional shoulder instability is more common in our male patients. When we think about shoulder instability, it can be either anterior, posterior, or multidirectional. Multidirectional instability is more likely in our female athletes, largely due to their association with joint hyperlaxity, opposed to unidirectional instability events, which is more commonly traumatic and found in our male athletes. Nonetheless, though, as we find increased female participation in both recreational and professional sports, there's increased exposure to injury, and in turn, increasing trends in the incidence of shoulder instability in our female athletes. So I think with time, we're going to see this needle move and, more research needs to be done on our female athletes. And so despite the rise in female sports participation, as I was just alluding to, there is a lack of research regarding female athletes' injuries, especially in the upper extremity. The specific incident rates for shoulder instability associated with individual sports is lacking for our female athletes. It's crucial that we bridge this gap and identify such specifics as we know, through the identification of specific sports where instability occurs, it gives us greater insight into the nature of the instability event, the mechanism for it, and then ultimately guiding the best treatment for our athletes. So what we do know, though, at least, is that there's a certain number of sports that are associated with shoulder instability for our female athletes, including rugby, which in the literature is found to be the most common sport associated with shoulder instability for our female athletes. This is followed by military obstacle training courses and combat training. Other sports that are associated with shoulder instability include basketball, swimming, softball, volleyball, and gymnastics. An interesting point I want to make is that when analyzing sports that are comparable between sexes, the rate of shoulder instability is more similar amongst males and females. Peck et al. Found that male and female rugby players at West Point had similar rates of dislocation over a 5-year period. So next, we're going to discuss the sex-specific risk factors as it pertains to shoulder instability in our female athletes. So studies have shown that hormonal variation can impact injury and instability risks. In a recent systematic review, it's been shown that elevated levels of the hormone relaxin and estradiol are associated with decreased collagen production, which in turn leads to decreased ligament and tendon strength, and therefore greater instability risks as the glenohumeral joint relies heavily on the soft tissues around it for stability. So furthermore, studies have also shown that women on OCPs have a higher level of estrogen and progesterone compared to those not on OCPs, thereby putting them at greater risk for shoulder instability. Then when we want to consider hormone levels during the menstrual cycle, we have to remember how they fluctuate depending on the stage that we're in. So studies have shown that there's been suggesting depending on the phase during the cycle that a female athlete is going through, that this can impact their shoulder proprioception and strength. So during the late follicular phase and the luteal phase, proprioception and strength were reduced compared to the ovulation early follicular phase. This is likely related again to hormones, where we have increased levels of estrogen and progesterone, leading to reduced collagen synthesis and ligamentous strength, leading to risk for instability. Another important risk factor for our female athletes is joint hyperlaxity, both generalized and shoulder-specific laxity. Shoulder hyperlaxity is an increase in joint translation due to greater than normal laxity of the capsule. This allows for increased glenohumeral translation, distractibility of the joint, increased active range of motion, and potential instability when the balance between the dynamic and static stabilizers is disrupted. About 10% of the population has shoulder hyperlaxity. About 5 to 15% of shoulder instability cases have joint hyperlaxity. Generalized joint laxity and specific joint laxity are both associated with our female athletes, which in turn puts them at risk for shoulder instability. Next up is the glenoid morphology. This is another important factor to consider. Compared with males, females have markedly smaller, thinner, and more oval-shaped glenoids with higher inclination angles and anteverted position. In addition, the height to width ratios of the glenoid are markedly different between males and females. So the combination of this osseous vulnerability, increased shoulder range of motion, and greater prevalence of generalized ligamentous laxity in our female athletes, in fact, increases their risk for shoulder instability. And then the last risk factor that we're going to discuss today is the difference in muscle mass between our male and female athletes. Females have less upper extremity muscle mass compared to our males. Less muscle mass in the upper extremity results in muscle imbalances in the dynamic and static shoulder stabilizers, in turn increasing their risk for shoulder instability. So some quick take-home points that I want to leave you with are, one, that there's an increasing trend in shoulder instability incidence in our female athletes. Two, sex-comparable sports show equivalent rates of shoulder instability in our male and female athletes. And last but not least, female-specific risk factors for shoulder instability include hormonal variation, glenoid anatomy, joint hyperlaxity, muscle mass, and of course, their biomechanics. So thank you everyone for your time and attention. We look forward to the Q&A session at the end of tonight.
Thanks, Dr. DeLuca. That was a great talk. Next up is Dr. Ashwin Babu, another primary care sports medicine physician who I have the great pleasure to work with at Mass General Brigham. And he is going to talk to us about current data on non-operative management and ultrasound applications for shoulder instability. Dr. Babu.
Thanks very much, Dr. Matzkin, for that introduction, and thank you all for having me for this webinar. So we'll get right into it. We're going to start with a brief anatomy review. We'll talk briefly about the classification schema that are used in shoulder instability. We'll go through some of the brief sex differences that we see in these cases, and then we'll spend most of our time talking about non-operative management, and we'll wrap up by talking about a few ultrasound applications as it pertains to the care of these patients. So, quick anatomy review. As everyone's aware, the shoulder is often referred to as the golf ball on a tee due to the relationship of the osseous structures. They have many degrees of freedom, but that comes at the expense of inherent instability. There are both bony and soft tissue restraints. Of the soft tissue restraints, they're both passive and active ones. The passive restraints, of course, the glenoid labrum, the long head of the biceps tendon, the glenohumeral ligament and its constituent components. The active ones, of course, are the rotator cuff, and it's important not to forget the periscapular stabilizers, which all have to work together to keep the ball in the socket during these dynamic movements. So let's talk a little bit about classification. So the one that's been historically used most commonly is the concept of unidirectional versus multidirectional instability. The two terms that are commonly used are the Tubbs versus Amory descriptors. Tubbs referring to the traumatic instability that's often in a unidirectional nature, that often is associated with Bankart type injuries, and they often require surgery. This is contrasted to those who have more atraumatic etiologies of instability. They tend to involve more multidirectional cases, bilaterally. They tend to do best with rehab, and if surgical procedures are needed, they tend to be more the soft tissue procedures like the inferior capsular shift. Then the Stanmore system was also put forth, where they tried to separate cases into three polar types based on the traumatic or atraumatic nature and the structural or non-structural injury. The Gerber system focused a lot on the static versus dynamic versus voluntary instability to help to separate patients. And what we've used most recently is the FEDS system. FEDS is an acronym referring to frequency, etiology, direction, and severity. And this has had more traction in more recent literature. Frequency referring to solitary, occasional, or frequent. Etiology, of course, traumatic or atraumatic. And the direction, of course, being anterior, posterior, or inferior, and severity really being split between subluxations versus true dislocations. And so that's what we've seen in more recent literature. So let's talk a little bit about some of the sex differences that we see in shoulder instability. So I tried to amalgamate this into an easy to digest table. Of course, the main problem here is that we really don't have enough literature. As Dr. DeLuca very eloquently discussed, there are many factors to separate these cases, separate males versus females as it pertains to shoulder instability. In general, males have the higher overall incidence of instability. They tend to be more traumatic and tend to be associated with unidirectional and anterior instability. And this is important because they're also at higher risk for labral and osseous injuries that, if you're thinking about non-operative management, those injuries also need to be addressed and paid attention to. The fact of the matter is that they tend not to do quite as well with non-operative management and have high incidence of recurrent dislocations and just suboptimal results. And so operative management is considered for these male first-time dislocators, particularly in high-risk sports. This is compared to female athletes. Well, based on some studies, also are the most common injury is a traumatic anterior dislocation. They overall have a higher percentage of atraumatic multidirectional instability. And so the rehab really needs to take the general ligamentous laxity into consideration. Many female athletes it's appropriate to trial non-operative management, at least initially. And if surgical correction is necessary, they tend to be a high percentage of more soft tissue procedures. So let's get into the pillars of non-operative management. If you have an acute dislocation while you're covering a sport, of course, the initial evaluation is the same as any traumatic injury. You verify safety of yourself and the athlete, do your BLS and ATLS surveys, clear the cervical spine, assess for fractures and neurovascular injuries. If it is safe to do so, an immediate closed reduction is the preferred method. Doing it soon is better until before muscle spasm sets in. It is very important to perform a repeat neurovascular examination after a successful reduction. And for those first-time dislocators, it really is appropriate to get imaging to verify that everything's back where it should be. And in someone who has had many, many dislocations, there's a consideration that perhaps that isn't strictly necessary, but overall imaging is a safe bet. What I have on an image on the right here are two very commonly described techniques in the literature, the Fairs and the Milch technique for successful closed reduction. Once you have them in more the clinical setting, then a careful history and physical exam is very important. Use the FEDS classification to understand what kind of injury you're dealing with, and then really getting information about their sport, their activity level, the timing of the season, and really getting all the other key stakeholders involved, be that parents, coaches, trainers, agents. Really having everyone together to help make the right decision for the athlete is important. It's also important to get an understanding as to whether or not you're dealing with instability in the context of a hypermobility syndrome. So in terms of that physical examination, which is very important, I pay a lot of attention to active and passive range of motion. I spend a lot of my time really looking at the scapular mechanics and the neuromuscular control. These are the deficits that we often need to pay most attention to. Rotator cuff strength is, of course, important, and then labral and biceps testing is critically important, depending on whether you're looking at the anterior, superior, posterior, or inferior labrum. There are a series of tests that have varying levels of success. Often a battery is needed to really get a good understanding. The Baton's criteria is a very successful tool to help us understand whether or not we're dealing with a general hypermobility syndrome. So in the acute phase, the main goal is to reduce pain, allow for tissue healing. We often use sling immobilization, particularly if it's a first-time dislocator, for the first couple days to about a week until pain is under control. Then we try to restore that pain-free range of motion, really focusing on neuromuscular control and parascapular stabilization, starting with isometrics, then moving towards more dynamic movements, and eventually towards sport-specific rehabilitation. That return to sport is criteria-based as opposed to time-based these days, and communication with the entire team is critically important. Setting proper expectations is critical to a successful case. In terms of the ultrasound, the mainstay of treatment for this really does not involve ultrasound. Really, we use plain films to look for dislocations. We use MR with an arthrogram to assess for the labrum, CTs to look for glenoid bone loss. But ultrasound does have a couple very successful things it can do. In particular, it can very reliably assess for dislocations and reductions, both anterior and posterior. The graph on the bottom is a series of studies looking at the sensitivity and specificity of assessing for dislocation and reductions, and you can see they're very close to 1. The graph on the right is a couple of studies looking at Hill-Sachs lesions, which can also be easily identified on ultrasound. Remember that all ultrasound studies are equipment and user dependent. The new things coming down the pipeline are dynamic evaluations and arthrographic evaluations. Here are a couple ultrasound images. This is the standard views that you'd expect to see on the left. On the right, I'll draw your attention to the top image, which shows the difference between the glenoid and the humeral head, which is really very minimal in the normal setting. The middle image here demonstrates a much larger difference, which is classic for an anterior dislocation, and in a posterior dislocation is even higher. And so these are really very easy to see. These images here are of looking for anterior labral injuries. This is via transaxillary approach, as shown on the right image here. On the very top, you can see some labral stripping, which you can see on ultrasound, and on the left, you can clearly see a Hill-Sachs lesion. So, in conclusion, the whole shoulder is inherently unstable. There are a variety of classification schema. We use the FED system most commonly. Acute management involves your typical closed urgent reduction. Subacutely, we work on sling immobilization and structured rehab. While males often have that anterior dislocation, multi-directional instability is more common in our female athletes. Non-operative management really focuses on neuromuscular control, and ultrasound is having a growing role in the management of these cases. Thank you all so much for your attention. I'm looking forward to the questions.
Dr. Babu, thank you. That was a fantastic talk as well. All right, so next up, we're going to hear from Dr. Giovanna Medina, who is an orthopedic surgeon who specializes in sports medicine at Mass General Brigham. She is going to talk to us about surgical management. What is the evidence, especially in our female athletes? Dr. Medina.
Thank you for the introduction and invitation to speak tonight. I'm excited to participate in this webinar. And as it was mentioned, I will talk about the surgical management of shoulder instability in the female athletes. So, as was mentioned previously, it is well known that males are more likely to have shoulder instability than females, and especially if they are young and participating in contact sports. And there's a lot of evidence that shows that these athletes have a high risk of recurrence if they are treated without surgery. In terms of sex differences, when it comes to shoulder instability, as you can see here in this graph, the truth is that there's not much in the literature. And maybe in the past 5 or 7 years, as you can see here, the increase in publications in this topic is where we've seen more interest in sex difference in shoulder instability. So despite males being more commonly affected by shoulder instability, we have seen an increase in prevalence in females with shoulder instability, and that's because they've been participating more in sports. And as Dr. DeLuca mentioned, there are important factors that we need to consider between females and males, difference in muscle mass, bone morphology, ligamentous laxity, differences in biomechanics and hormones. These will all guide our decision-making and influence outcomes in the surgical treatment after shoulder instability. So in the next few slides, I will bring what we have in the literature showing the treatment of shoulder instability in the female athlete. These two studies here, they demonstrated that females actually have a decreased shoulder function and more instability even after the repair of the labral. It's not that they're going to dislocate more, but they feel a little bit more lax, and that could be probably because of their increased ligamentous laxity from baseline. Females have a decreased rate of redislocation. So here they are looking more at the chances of the shoulder dislocating again, and actually males are more likely to have recurrence. And that is probably because they are more involved in collision type of sports, which are more risky for these type of injuries. When it comes to other stabilizing procedures, the Lauder J is a technique that you transfer the coracoid into the front of the glenoid, and that is usually indicated when you have glenoid bone loss or in the revision setting. And these studies demonstrated that females that have undergone Lauder J procedures, they have lower functional scores and lower return to sport rate as well. This is a great study from the Moon Moon group that analyzed a big cohort. They had more than 1,000 patients, and they demonstrated that males, they have more bone loss after dislocation, and therefore they're more likely to need a lateral J procedure, while females, they have more soft tissue pathology, and so more likely to need only the arthroscopic labral repair. And so not only do we need to think about all these different techniques and options for surgical treatment of the female athletes, but we also need to think about the post-operative course and obviously complications. And unfortunately, we don't have many studies on these topics focusing on sex difference. This is one of the only studies, and they looked into the complication rates after 30 days from surgery, 90 days, and 2 years after lateral J. And what they found was that females actually have an increased risk of complications in the first 30 days, and they are more likely to need a visit to the ED. They didn't find any difference, though, in the 90-day after surgery or 2 years after surgery. Now, mental health is something that was not really addressed in the past. It's maybe in the past 5 years or so, and thankfully for several famous athletes that share their stories, we've been focusing more on the mental health aspect in relations to any kind of injuries, to be honest. And this is a study that demonstrated no difference in clinical outcomes. However, the females, they were more likely to have worse mental health at the 2-year mark. And other thing that we have seen a shift in the literature is in regards to how we analyze outcomes after surgeries. And instead of just looking into scores from before and after surgery, some clinicians and researchers are now using the MCID, or minimally clinical importance difference, and the PASS score, or the patient acceptable symptom state, because we want to see not only before and after surgery, but if the procedure that the patient underwent was actually helpful in terms of whatever their goals are. And this is a very interesting recent study that actually found that females need a lower MCID and PASS score after surgery for their shoulder, which is something to think about and obviously needs more study. So in summary, there are several sex differences in regards to shoulder instability, and the current data that we have available show a lower recurrence rate after labral repair. And although they have lower recurrence rate, they have lower outcome scores, either after labral repair or lateral J procedure. And they also are less likely to return to sport compared to male athletes. But definitely we need more studies and high quality studies to understand better other topics on shoulder instability and be able to treat better our female athletes. And that's all I have for today.
Excellent. Thank you, Dr. Medina. Next up is Stephanie Boudreau, who is a physical therapist at Mass General Brigham, who specializes in taking care of our athletes with shoulder problems and works on their return to sport protocols. She is going to outline some rehab strategies for us, especially with a focus on female athletes, emphasizing progression benchmarks and recurrence prevention. Well, Stephanie's pulling up her slides. I can throw out a question. How about for Dr. Medina? Do you consider anything specifically different when you're taking care surgically, your females versus your male athletes?
Yes, so as was mentioned by Dr. DeLuca and also in my presentation, the increased hyperlaxity, you might want to when you're doing a labral repair, get more of the capsule and incorporate that in your labral repair to make them a little bit tighter, because they will stretch out after your surgery. That's one thing. If you're doing a bony procedure, let's say a letter J, they have smaller glenoids, but they also have smaller coracoids. So you really have to do a preoperative planning to make sure that the amount of coracoid that they have will be sufficient to make up that bony loss that they have. And they might need something else like an allograft or head inhibinate, which is getting bone from the iliac crest.
Thank you. All right. Steph, you looking for slides?
I am.
Okay.
I'm not sure which window to go in.
So if you go to share,
Mm-hmm.
then you should be able to share your screen and your slides with all of us.
I think so.
On the bottom of your Zoom screen, you should be able to share.
Again. Saying share screen. Okay. Are we there? No. Jeez, you guys.
Okay, so we almost saw your slides.
You did?
So yep, open your slides up on your screen. There you go. All right, and go.
Okay. I got it. Sorry, guys. Okay, thank you, Dr. Matzkin, and everybody else for your patience with my IT issues. It's definitely an honor to be here tonight with this group. I'm going to be discussing the rehab implications to return to play for the female athlete, specifically with shoulder instability. This talk is definitely by no means conclusive, but a few key concepts I felt were relevant to bring up tonight. So my three specific objectives are to the differences in progression for female athletes with shoulder instability, specifically looking at the importance and differences of strength and stabilization, ligament laxity and its influences, which Dr. DeLuca discussed earlier, and the importance of addressing the kinetic chain. My criteria for safe return is looking at the importance of combining a general strengths program with sport-specific training, focusing on stabilization, mechanics, and in respecting muscle fatigue. And as Dr. Babu also discussed, the importance of a multidisciplinary approach. And I want to end briefly with discussing the role of functional outcome measures and how this may assist us in customizing training programs for our female athletes. We're all familiar with the emphasis and importance placed on strength training. Strength's the ability of muscles to produce force against a type of resistance. This helps the athlete perform the physical aspects of sports and enhance performance. Larger muscle groups in this upper quarter could be anything from biceps, triceps, the deltoid group, latissimus, pectoralis major, to mention a few. But stabilization, in my opinion, and unfortunately in my experience, is generally not discussed or implemented enough in training programs. It's specifically when we're working with this athlete with the unstable shoulder. Stabilization, as it's defined, is the ability to control movement around a joint, assisting in maintaining joint alignment. These include some of our smaller muscle groups in the upper corner, specifically the four muscles of the rotator group, periscapular musculature, and the core, which I'll discuss later when talking about the kinetic chain. Dr. Medina and Dr. DeLuca both discussed more specific data regarding male and female dislocation types. So I'll briefly touch on it again, yet with more emphasis on female implications. So female athletes have a more ligamentous laxity compared to their male counterparts, more commonly contributing to higher incidence of non-traumatic dislocations and presenting more frequently with MDIs or multidirectional instability. This increased inherent laxity may contribute to higher percentage of overuse injuries. And both Dr. Babu and Dr. DeLuca discussed anatomical factors in that morphology of female shoulders can contribute to increased laxity, as well as hormonal influence, which I'll discuss in more detail as this topic needs to have more discussion and regularity with our female athletes. So hormones and timing of fluctuations can have both positive and negative effects on muscle strength, neuromuscular control, as well as proprioception. Having a better understanding of this may assist coaches, trainers, and physical therapists to customize strength training programs and optimize optimize athletes' training. And it is worth mentioning that during puberty for females, generally anytime between ages of 8 to 13 years of age, there's significant hormonal changes that can contribute during this period that may increase joint laxity, alter mechanics, and potentially increase the risk of injury. So I do feel repeating details regarding hormones discussed earlier is important because estrogen and progesterone fluctuate at different times during the month, and educating female athletes and their coaches may help in decreasing injuries as well as optimizing training. Estrogen is a very beneficial hormone in supporting muscle recovery and collagen formation. However, with increasing levels, it can increase ligament laxity and potentially lead to higher risk of injury. Progesterone, also important hormone in helping regulate menstrual cycle, as well as other things, can increase joint laxity when levels are high, which can exacerbate symptoms in our hypermobile athlete. This slide just breaks down the average timeframes of the menstrual cycle and progesterone of estrogen and progesterone and when they're at their peak levels. Moving on to my second objective, the importance of mechanics. The shoulder joint is one of the most dynamic and mobile joints in the body. In our female athletes with shoulder instability, this can certainly be challenging. We need to understand our shoulder mechanics. Strengthening can be detrimental in the presence of an unstable shoulder if mechanics are poor. We have to ensure that our athlete and the coaching staff understand the shoulder mechanics and is able to implement them prior to any strength progression or stabilization progression. We also should be mindful of motor control, and we should respect muscle fatigue, as an unstable shoulder can generally be inefficient. I wanted to briefly emphasize the importance of strengthening the entire body. During most sports, the arm is often the last part of the body to move. Treating and strengthening the entire body to ensure proper transfer of energy with good core stability that will enable all shoulder joints, not just ones with instability, to efficiently perform its function. As we start moving more towards sport-specific training and emphasizing the importance of strengthening and stabilizing the entire kinetic chain is imperative. So some general criteria for safe return to play specifically with this population is multifactorial. However, a vital component is to listen to your athlete. Respecting apprehension. Unless you've had shoulder instability or a history of dislocation subluxations, we don't fully understand what the concept of apprehension means. If your athlete expresses that her shoulder feels loose or unstable, try to prevent them from continuing with training and certainly with continuing to play. And finally, sport-specific training. PTs are not coaches, and generally we're just not specialists in sport-specific techniques. It's important to establish a multidisciplinary approach, communicate with all members of the athlete, the surgeon, the coaches, the lift trainers, the athletic trainers, and even parents to help maximize the athlete's training. Finally, I wanted to end my talk about the potential benefits of functional outcome measures. Dr. Matzkin and I and some of our colleagues published a paper back in January of 22 that looked at systematic reviews and how males and females differed in various outcome measures. We found that males and females repeatedly scored differently on outcome measures within similar sports, implying that we cannot continue to train our female athletes pre-mid or even post-season like their male counterparts. Future may look at not only at sport-specific outcome measures, but also sex-specific targets, sex-specific to target different areas between sexes that may assist in preventing injuries. This is just the abstract of our paper. And in conclusion, we need to have a better understanding of ligamentous laxity in all female athletes from both an anatomical and a hormonal approach. We should be incorporating a robust training program that includes strengthening as well as stabilization and an open communication with all of our athletes. We need to ensure, as Dr. Babu emphasized, a multidisciplinary approach, and we need to continue research utilizing functional outcome measures. Thank you. I look forward to your questions. And again, I apologize for my IT difficulties.
Great. Thanks, Steph. So you can stop sharing and I will introduce our next speaker, which will be Dr. Rachel Vanderkruik, who is one of our sports psychologists at Mass General Brigham. who really works with us to integrate evidence-based psychological strategies to optimize athlete well-being and performance. And she's going to talk to us about the psychological impact of shoulder instability in female athletes, including fear of re-injury and strategies to support mental readiness for return to sport or return to play. All right, so Steph, if you can click on the stop share button on your screen.
Hi, everyone. My name is Rachel Vanderkruik, and I'm a clinical psychologist with the MGB Women's Sports Medicine program. So I'll be speaking today about psychological considerations in female athletes with shoulder instability. As my colleagues have highlighted in the other talks today, shoulder instability is relatively common among female athletes. And joint laxity tends to be more prevalent among women, which can heighten the risk, the physical risk of instability, and may contribute to feelings of vulnerability or fear of re-injury. Behaviors around reporting symptoms can be shaped by broader cultural and psychological factors. For example, shoulder instability may be underreported because repeated slips could be normalized in some sport teams, or cultural pressures around toughness or stigma associated with being seen as injury prone may discourage any help-seeking behaviors. So it's important to be aware of how these influences could impact female athletes' willingness to report symptoms or to engage in treatment. Beyond the physical aspects of recovery, psychological factors can play a key role in returning to play outcomes, yet often receive less attention. So that's what I'll focus on in this talk. Injury often brings psychological distress and can trigger, uncover, or exacerbate, underlying issues like perfectionism or feelings of isolation, which may have been previously managed through sport and physical activity. We encourage watching for hypervigilance, where attention shifts from engagement in play to a focus on pain or body positioning following an injury and returning to sport, which I'll return to shortly. It's important to also screen for clinical mental health concerns, such as depression or anxiety, that may require more intensive and specialized treatment. As part of the mental health screening, it's important to assess for nutrition and eating behaviors during recovery. Injured female athletes may worry about body image or weight gain with reduced activity. And this could lead to disordered eating behaviors, such as unhealthy restriction of calories, which could, of course, negatively impact physical and mental health and the overall healing process. As previously noted, experiences such as fear of re-injury and hypervigilance can change the biomechanics and decision-making when returning to sport, often driven by a lack of trust in the injured shoulder. Even after a technically successful physical repair, these fears could prevent athletes from returning to their prior level of play. What's referred to a concept of psychological readiness has been found to be strongly linked to successful return to sport and performance, highlighting the need for interventions that help to rebuild confidence, trust, and management of anxiety, in addition to addressing the physical aspects of strength and rehab. And adherence to a rehab program for a shoulder injury can be challenging. Many athletes may describe the process as monotonous or frustrating over time. So using clear, attainable goals and other psychological techniques listed here, such as imagery and exposure, can help to sustain motivation and rebuild confidence in returning to play. It's also important to assess for and strengthen social support, as social dynamics may have shifted on a team or in other ways due to an athlete's injury. Our psychology team provides brief and targeted interventions for athletes recovering from injury or facing sports-related challenges. So when a referral comes in, we start with a comprehensive evaluation covering mental and physical health history and assessing related factors and creating a treatment plan. We focus on providing education about injury and recovery and psychoeducation and teach evidence-based skills that help athletes manage the mental side of sport and recovery. For example, we could normalize mixed emotions and encourage dialectical thinking. For example, it's okay to feel both proud of a teammate and also frustrated about not playing at the same time. We use exposure techniques to gradually face physical activity-related fears as athletes are medically cleared. And we can emphasize concepts such as acceptance and self-compassion, reframing the recovery process as a period of growth, an opportunity to build mental toughness, rediscovering maybe joy in movement, and even strengthening connections and interests outside of sport. We often draw from cognitive and behavioral principles, starting with awareness of how thoughts, emotions, and physical sensations relate to one another during the recovery process. Focusing in on thoughts, the goal is to learn that thoughts are not facts, and we work with athletes to help identify unhelpful patterns in thinking, to shift perspectives, and to encourage more balanced and helpful thoughts that support recovery and performance. Recognizing unhelpful thinking patterns, such as catastrophizing or black and white thinking, can help athletes notice when thoughts might be holding them back. Such patterns can often lead to frustration, low motivation, or hopelessness about the recovery process. So by challenging and reframing these thoughts, athletes can improve their emotions and also work to redefine any sense of self-identity as needed, seeing themselves as capable, adaptable, and still an athlete even while injured. Mindfulness is a skill that helps athletes stay grounded in the present moment and notice physical sensations and emotional experiences without judgment. Just like a muscle that gets stronger with exercise, athletes' capacity to direct their attention to what they want to focus on gets stronger with practice. So mindfulness is a technique that can help to build focus, resilience, and mental toughness that can strengthen performance and support the recovery process. So to wrap up, some key takeaways I'd like to emphasize are that female athletes face unique mental health challenges during injury and recovery that warrant as much attention as physical factors. We want to encourage psychological screening for mental health conditions and concerns alongside the physical aspects of return to play. It's important to foster and normalize open conversations about fears of re-injury and trust in the injured shoulder. And effective rehab integrates physical and psychological skills, often including graded exposure and tailored evidence-based skills. And last but not least, recovery is strongest when supported by multidisciplinary teams, so including physicians and psychologists, nutritionists, coaches, often working together to support the athlete. And with that, I'd like to thank my team with the MGB Women's Sports Medicine team. Thank you so much.
Awesome. Fantastic. Well, you guys did an amazing job. So there are a couple questions in the chat, and I have a few questions that I can also would love to ask everyone. So one of the questions in the chat is, does the patient's age at the time of surgical treatment affect outcome or return to sport? For example, adolescents versus adults. So Dr. Medina, I'm going to throw that one over to you since you take care of that age group.
That's a very good question. What we know is that adolescents who have shoulder instability and they have It depends on the treatment. If the treatment is arthroscopic labral repair, they have a return to sport rate that varies between 80 and 92%. If they have a more complex procedure, such as a bony procedure, Lauder J or DTA or any type of other bone block, they do have high return to sport rate, but lower than arthroscopic labral repairs, which is around the 70% mark. Older individuals, in fact, you have to consider that they're not really participating in competitive or highly competitive sports such as our high school and collegiate athletes, but they have a similar return to sport rate, and although at a lower level of competitiveness.
Thank you. So I was going to throw a little bit of a case out. So let's say we have an 18-year-old female soccer or football player, depending on where you live, who's had a first-time shoulder dislocation at the end of soccer season. And she presents to your clinic. So Dr. DeLuca, any thoughts on how you first want to determine if this is true traumatic instability, or is there a component of generalized ligamentous laxity that's contributing?
Yeah, that's a good question. So I mean, for me, it's really asking their history of like any prior shoulder, instability events, knee instability events. That would give me a sense too if there's like generalized joint laxity, any family history of any, prior dislocations, instability events. So I think that's really important. That's what I do with a lot of my patients to kind of identify those risk factors for them. And then of course, then on our physical exam, doing a Baton score to see kind of where they are objectively.
Perfect. All right. So, so she then somehow ends up in your clinic, Dr. Babu. And so what would be your top, few physical exam tests to kind of assess this athlete who's had their first-time shoulder dislocation?
Yeah, certainly. So the first thing is a general screen of kind of scapular motion. And so we'd first check their active passive range of motion, the rotator cuff screen, and then really get a good idea what the periscapular motion is like. So a lot of my T and Y motions to really make sure that the scapula are moving equally and have excellent neuromuscular control. And particularly paying a lot of attention in some of the more provocative maneuvers, for instance, in that Aber position. And then in terms of the kind of nitty-gritty of how we're assessing this, because the anterior dislocation is by far the most common. The test that's really going to be most useful will be the apprehension and relocation test. So I'll have them supine, bring them into an Aber position very gently, paying close attention, looking closely at their face, and really asking them to give me verbal confirmation when I need to stop. And I'll get an idea as to how far back I can bring them before we really start to have true apprehension. And then you can provide a posteriorly directed force of the anterior shoulder to see if that provides a little difference, and then remove it, of course, to see what that changes. And then if they even can't tolerate that, another test that I'll often use is kind of the load and shift, which is a little more comfortable a position. I can keep them in a seated position. Those are the ones that are most useful. For that, some folks who we are worried about a general ligamentous laxity will look for a sulcus sign, which effectively typically is the more inferior aspect of the labrum. You can do the gauge or hyperabduction test where you stabilize the scapula, bring their arm, and see if they can get past that 100, 115 degrees of pure abduction. Those can give you clues. The combination of those really answers my question pretty classically.
Perfect. So this patient has an anterior inferior labral tear, which is what we most commonly see in these first-time dislocators. So Dr. Medina, the million-dollar question, do you offer this first-time dislocator surgery, or do you try and manage this non-operatively? So 18-year-old female soccer player, end of season, where do you want to go with this?
That's a very good question, because we actually have to take into consideration several things, and the discussion might be different if the patient plays other sport, if they are, in season, and what really are their goals for the future. So what I usually discuss with patients and their families is what we have in the literature. So we know that the younger they are, if they are playing sports, and especially males, they have an 80% chance of redislocating again if they don't fix this. And if they don't fix it and they have another dislocation, the risk of having additional injuries is high, which can mean having bone loss, having a Hill-Sachs, damaging more their labrum, and then they might not be a candidate to arthroscopic labral repair anymore, which means they will require a more complex procedure. But yes, I think non-operative treatment is an option, but you have to discuss all the risks and complications that can happen if they don't fix this.
Thank you. So let's just assume Dr. Medina took this patient to the operating room and did a beautiful labral repair. And now they're seeing you, Stephanie, for their post-operative rehab. What would you say would be the 3 most important considerations that you think about when you're rehabbing a post-operative shoulder instability patient? And just take yourself off mute.
First, I wanted to say that, early in my career, a lot of these patients were not getting surgery at all. So it's nice to see how that has changed literally in the last 5 to 10 years at the most of my career, and they're doing so much better. And I do agree with Dr. Medina that I am seeing it much more with males and females. However, I have had quite a few patients post-operatively, males and females, with these bank heart repairs. And the biggest thing I look at is the level of instability that they have. Are they still complaining of any instability in any of the planes of motion? I'm looking at scapular mechanics on how they're moving. A lot of these patients are strong, even post-operatively. They're wanting to move. They're not in a lot of pain. And so they're moving with a lot of compensatory motion. So the second thing I'm really looking at is their scapular mechanics through all planes of motion. Then I'm going back to address length, tension, and soft tissue imbalances. I think a lot of them are prior to their tears or compensators, which may or may not have contributed to that. And so I'm looking at length, tension all around scapular borders, periscapular musculature, anterior chest wall, looking at tissues that are too short, looking at tissues that are too long, and really implementing better length tension prior to any even active range of motion way before strengthening. I think the third part that I would look at is what Dr. Babu spoke about, is the importance of cuff and periscapular strengthening and avoiding compensatory, what I refer to with my patients as power bully muscles prior to that.
Thank you. All right, so I see another question is any form of menstrual cycle tracking used by the teams or taken into consideration during prevention of primary tears or re-tears? So is anyone tracking menstrual cycle in these female athletes? No. So yeah, we have been talking about this and are starting to collect this data, but I'm almost disappointed that I haven't been collecting it over the last many years, but hopefully we can learn a little bit more about how the menstrual cycle and hormone fluctuations may affect shoulder instability or, revision instability.
Liz, I think I brought that up a lot in my talk for the simple fact that, as physical therapists, we are spending a lot of time with these patients. We're seeing them anywhere from, 2 times a week from, months on end. And a lot of my females tend to be more comfortable talking to me about these things and not their coaches, even their female coaches. So I think that putting this on the radar is very, very important. And even having all of you educate us as therapists, trainers, coaches, on how to better track this and assist it with their training programs could be very, very helpful.
I agree. All right, well, we're coming up on the end of the hour here, so I really want to take a minute just to thank our amazing panelists and speakers. And thank you all for continuing to kind of drive women's sports medicine forward with the work you do and the thoughtfulness you have. I'd like to thank our audience members and let everyone know that this will be relive or replayable after its recording. Thank you, everyone.
Thank you.
Thank you all.
Thank you.